All right, well, thanks so much. Yeah, I really am so excited to be able to present this to you. I think, as Wendy said, it really gets at all of our missions to connect, to educate, to empower. And I'm privileged to be the education portion of this, and really want to give you all some information that will help you to make decisions and understand epilepsy. And so Wendy said she was seeing a lot of familiar faces, so hopefully I'm really talking to people who already know what I'm talking about. But I will act as though that's not the case. And I was assigned to kind of go over the basics about epilepsy. And so I thought, since, again, the program is highlighting this statistic about 1 in 26 people, I thought we would start with a little introduction about epidemiology and learn about some terms that physicians use to talk about epilepsy and other medical conditions and how common they are. So the first would be the term prevalence, which actually means the number of people in a population with epilepsy at any given point in time. So if you look at that across the world, there are 50 million people with epilepsy. In the United States, there are 2.2 million people with epilepsy, and there are 60,000 people in Colorado with epilepsy. So that is the prevalence of epilepsy. The incidence of epilepsy is the number of new cases of epilepsy diagnosed in a given period of time. And sometimes it's reported for a year, sometimes it's reported, like this Th1nk26 statistic, for a lifetime. So some other statistics that are relevant: 1 in 10 people will actually have a seizure in their lifetime. They do not necessarily have epilepsy, but they may have a seizure. Every year, about 150,000 Americans are diagnosed with epilepsy, and during their lifetime, 1 in 26 people will be diagnosed with epilepsy. Epilepsy is currently the 4th leading cause of neurologic disease in the United States, after migraine, stroke, and Alzheimer's disease. But if you look at the actual numbers, epilepsy is more common than MS, Parkinson's, and ALS combined together. And I think the startling thing about this statistic, this 1 in 26 statistic, and the report that it came from, called the Institute of Medicine report, is that despite the fact that our numbers are more common than all of those other conditions, our funding is less for research and development and improvement of the lives of people with epilepsy. Epilepsy has 2 peaks of occurrence: one in children, young children, especially those under the age of 2, and then another peak in the elderly population, often related to stroke or other types of neurologic disorders. So next, I'd like to talk a little bit about the definition. What is epilepsy? And this is something that can be kind of actually quite complicated. It's been through a lot of iterations. Doctors like to kind of classify things and put them in categories and give them names, and then change their mind 5 years later and put them into different categories. So, so this actually is kind of an evolving thing, but I think the standard things are to understand, number one, what is a seizure, because that's the hallmark of epilepsy. So a seizure is defined as a sudden and involuntary alteration in behavior, and that can include your motor function, autonomic function, meaning things like sweating, heart rate, breathing rate, your goosebumps, those types of things are autonomic functions, level of consciousness or sensation that is also accompanied by an abnormal discharge in the brain. And so those are the 2 key features. Kind of one part is what's happening in the brain, and then the other part is what you're kind of seeing in the person. I think defining a seizure on the molecular level, what is actually happening within the brain from cell to cell, is actually quite challenging and something that we still don't fully understand. But basically, if you think of, kind of 2 systems within the brain: one, the gas pedal that activates and causes neurons to fire and, produce communication between cells, and then another system being the brakes that inhibits neural activity and kind of stops things or dampens down the activity of the brain. A seizure is essentially an imbalance between those 2 things. So too much gas and not enough brake. And all those nerves and cells within the brain, or not all of them, but some population of them will begin to fire synchronously over and over again. And that's what actually generates the seizure. So if we take that and then we say, well, okay, that's a seizure, but what actually is epilepsy? So the classic definition that has been around for many, many years is that people need to have 2 or more unprovoked seizures separated by 24 hours in time. And the terms there that are important are, number 1, unprovoked. So as we said, anybody can have a seizure. 1 in 10 people will actually have a seizure in their lifetime. And a seizure is really just this perturbation of the brain. It can happen if you get hit in the head with a baseball bat. It can happen if you have meningitis. It can happen when you're a child, if you have a high fever. It can happen if you're allergic to a medication, you can have a seizure. All of those things can result in a seizure, but those types of seizures are considered provoked seizures. So there was something in the immediate short term that happened that caused you to have that seizure. Whereas people with epilepsy can have a seizure without any of those triggers or antecedent events. It just happens, and they have this tendency to have them over and over again. And so that 24-hour period was designed to say, okay, if that person had a head injury and they had a seizure right at the time of the injury and another one a couple of hours later, that's still within that same time period, and we wouldn't call that second seizure unprovoked. Again, also if there was an illness, that second one needs to be kind of separated by some time. So that's kind of the classic definition that's been around for a long, long time. Recently, they kind of revised this definition for a variety of reasons. And the ILAE, which is the International League Against Epilepsy, is kind of the governing body of epileptologists around the world. Sponsors a lot of research, makes guidelines, those kinds of things, came out with this new definition. And so their definition is that epilepsy is an enduring predisposition to generate epileptic seizures and the neurobiologic, cognitive, psychological, and social consequences of this condition. And I think they felt that it was very important to put those other things into the definition, because it's been kind of evident to us and growing in our knowledge that epilepsy is actually more than just seizures. There are a various number of other neurologic consequences that can come from the brain having this predisposition and having seizures that go along with epilepsy. And so I think they wanted to highlight that first. The second is that they wanted to highlight that it is a disease. And the reason that that was important was because previously they kind of defined it as a disorder, and they felt like that really didn't convey to people in the community, in the general community, the seriousness of this condition. And so I think they felt it was important to change it from a disorder to a disease, even though it's kind of a conglomerate of things that have different causes, and it's not all exactly the same thing. That's true for many other conditions, and they didn't feel like that should prevent them from using that term. So they defined it as those things, but they also said, you know, some people want to be treated, especially adults, after one seizure. And if we're sure that they're going to have a second seizure, is there any way that we can kind of have the diagnosis of epilepsy kind of right off the bat at the beginning? And so we know from statistics that if a person has a single seizure, their probability of having a second seizure is probably about 60-ish%. Many of those people may just have a single seizure. Once you have a second seizure, the probability that you will have additional seizures goes up more dramatically and approaches, 90 to 100%. So they said, well, if after a first seizure, you can take a history from someone, you can do some testing, you can figure out what's going on, and you can say, that person has probably a 75 to 80% chance of having additional seizures, they probably meet the criteria of epilepsy at that point in time, and then kind of should be included under the same umbrella. So that's what those first several things in that list mean. They've kind of modified this definition and actually, made it a bit more complex. The last thing is that if you can diagnose someone with what's called an epilepsy syndrome, and I think that'll be important as we get to the next couple of slides. So an epilepsy syndrome is kind of a collection of certain factors, and those factors are: what kind of seizures does the person have? When did those seizures start? Are there any, what is the particular cause of those seizures? What does the EEG look like? How do those people respond to treatment? So that loose collection of things can make this diagnosis of a syndrome. Now, that's not to say that everybody inside of that classification responds exactly the same, but it kind of gives us another level of classification. So if you can talk to someone and put them into that category based on all of those things, then you can diagnose them with the syndrome, and therefore they have epilepsy because they have an epilepsy syndrome. So, so that was the kind of the revision that was made most recently. They also talked about when can you think that epilepsy is resolved, and that's a new aspect of things as well. And so they kind of broke that down into a couple of specific categories. So people who have what's called an age-dependent epilepsy syndrome, but are past that age. So many of the childhood syndromes typically resolve by, often by puberty. So childhood absence epilepsy or benign Rolandic epilepsy with centrotemporal spikes, those are age-dependent syndromes that resolve by a certain average age. And so if a person is quite beyond that and has been seizure-free, that epilepsy is most likely resolved. Also, if we look at kind of the general population of epilepsy, if someone has been seizure-free for 10 years and has been off of medication for 5 years, statistics say that it's very, very unlikely and close to zero that that person will have another seizure. And so they feel like we can say epilepsy is resolved. So that was another important aspect of this definition. So here is actually the report about how we organize seizures and how we talk about them. And obviously it's pretty complicated, but I just wanted to highlight a few things. So what I wanted to highlight was that in general, we kind of put seizures into two bins. One bin being generalized seizures, meaning that the seizure likely arises from some deep structures in the brain and spreads to involve the entire cortex at the same time. And there are several different varieties of that type of seizure, but that's kind of the pattern, and it usually has certain EEG patterns and certain syndromes that go along with it. And then on the other side, we say focal seizures. So seizures that arise in one part of the brain and then may spread a little bit. They may spread to involve the whole brain, but they start in one part. And so this is really the kind of way that we are trying to focus on describing seizures. And that's important because treatments are often different between those two categories. EEGs are different, MRI findings are different, and they kind of represent a lot of different aspects of epilepsy. You'll see on the other side that there's this unknown category, and that usually means that we don't have enough information to understand that. So the person may have had a convulsion and they don't have any features that anybody else saw that would tell them that the seizure started in one spot, or their EEG is normal and they don't have anything on MRI to point to a particular area where the seizure may have started. So we just don't know enough to say, yes, it falls into this category, or no, it falls into this other category. And then there's also a particular type of seizure under there called epileptic spasms, used to be called infantile spasms, and that can really come from either of those categories. And we also really don't understand all of the networks that are involved in the generation of that particular seizure type. So it kind of gets stuck over there when we don't really understand it. So, so this is kind of the big categories. You might have been used to hearing other words like petite mal or grand mal or complex partial or simple partial. Those are terms that are kind of common in the general lexicon of people's vocabularies, but are not typically used anymore in the epilepsy community by the docs and the care providers, because they are thought to be kind of out of date, and we're trying to focus more on these particular terms. So they focus on what happens in the seizure. So those focal terms you'll see broken down, and they say, what are the features? And so that's why it's really important for the doctor to ask, what is the first thing that happens when a seizure starts? And then they'll put it into one of those categories. Is it that the hand postures, or is it that you get a funny taste in the mouth? Is it that your heart starts racing? That would be an autonomic feature. So knowing that information and trying to think about how you feel during a seizure, or what someone else that you know feels during a seizure, is really important for the epilepsy professional to understand what category to place them in. And so I just wanted to go over a few terms so that, again, as part of this education, you would know the words that your doctor may be using in talking to you about seizures. And so we kind of, again, put them under these categories of motor seizures versus or motor symptoms versus non-motor symptoms. So the motor words that we use, so clonic, that is sustained jerking of a body part. So typically it's pretty slow, a couple of jerks per second. It involves a quick jerk and a slow relaxation of the muscle, and that's that word, clonic. Tonic is posturing, so stiffening and contraction of all the muscles. You can kind of feel the person be quite stiff, so that's called tonic. Atonic, or what used to be called drop seizures or drop attacks, are a sudden loss of tone where all the muscles kind of become limp and weak at the same time. The person may fall. This is the kind of seizure that many children will wear a helmet for because they can't control it. It comes on quite quickly, and they may bash their head on the table or on the corner, on the floor. And so that's the term for that. The proper term for drop seizures is atonic seizures. The next word there is myoclonic. So you recognize clonic from the first line. So that's jerking. Myo is the Latin word for muscle. So muscle jerking is that word. And that can be a part of the body. So it can happen in just the arm. It can happen in the whole body all at the same time. Often it happens in the muscles of the core close to the center of the body. So the neck, the shoulders, the core muscles, but it can involve other parts of the body. The next word there is dystonic. So dys meaning abnormal, tonic again meaning stiffening or posturing. So this often happens with a hand. So you may see the hand kind of adopt this unusual posture. Writer's cramp is a form of dystonia, so it kind of fits with that. Sometimes that can be with a foot or with the arm kind of coming up, or the face having a posture to it. So that's dystonia. And then the next word often goes along with temporal lobe seizures, this word called automatisms. So those are more complex movements of the body, so not just a posture or a twitch, but something that looks like it might be kind of purposeful. Sometimes these are the people, when they have automatisms, that are thought to be intoxicated or on drugs when they're out in the community, because they look like they might be kind of with it. They may be still walking, but they're kind of picking at their clothing, or they may be fumbling with something or chewing. They may be swallowing repetitively. All of those things are called automatisms. And again, many of them go along with temporal lobe seizures. So those are motor symptoms. Then we move to non-motor symptoms, which are kind of more internal sensations that people feel when they're having a seizure. So many of them can be psychic, so emotional feelings, fear, déjà vu. The other term is jamais vu, which has never been somewhere before, even though it's a familiar place. Sometimes this can also be an impending sense of doom or some other emotional feeling. Sensory symptoms, so when seizures activate the sensory parts of the brain, people can feel tingling in a various body part or numbness. Usually there's what we call a positive symptom, meaning it's not loss of sensation, it's an abnormal sensation, like tingling or pinpricks or sometimes even pain. And then sometimes when the visual cortex or the auditory cortex is activated, people may actually hear things. They may hear a ringing or muffled voices, a familiar song. They may see some shapes or colors, things of that sort. So those can be the beginning of seizures. We talked a little bit already about autonomic symptoms, so part of your automatic nervous system that controls your bodily functions. Those things can be activated during a seizure. And then altered awareness, so that's again the level of consciousness associated with the seizure, and that can vary between completely normal and fine to completely unaware of what's happening around you. And so the person may not respond to questions being asked to them, or they may respond, but they may respond slowly or abnormally. Sometimes they will be in the middle of doing something like cutting their food and bringing it right up to their face and stopping there. So what's called a behavioral arrest. They're suddenly stopped doing what they were in the midst of. So those are all not what we would call non-motor symptoms of a seizure. And then the last word I bring to your attention is called the ictal phenomenon. So ictus means seizure. And so we use those things to talk about what's happening during the ictus, during the seizure. And then post-ictal would be after the seizure. And there are some things that can be very important to know about what happens to people after a seizure. So as you may know, the left side of the brain, or that's the right side, the left side of the brain controls the right side of the body, right? And the right side of the brain controls the left side of the body. So if after a seizure, someone is profoundly weak on their left side, that may indicate to the doctor that the seizure started in the right side of the brain. Conversely, if they have trouble talking after the seizure, they can't use language, they can't understand what people are saying, that might indicate that the seizure started on the left side of the brain, which is where we typically put our language for most right-handed people. So knowing things about how you react, not just during the seizure, but even after the seizure, can be really important to explain to your physician. So we touched upon this already. Syndrome, a characteristic set of symptoms and signs that occur together and define a particular disorder or disease. And so I've just listed some of those things again. And then the word etiology, which is a fancy word for cause, and we'll go over that in a little bit. So there are, at least at the moment, around 30 syndromes, particular syndromes that are recognized by the ILAE, and I've put them here in this, don't worry about learning this very succinct slide of categories, right? So mostly this is a very common slide that we work with and use with all of our trainees, but it divides the epilepsy syndromes into age of onset, which is a very common way to think about them. So some begin in the neonatal period, some begin in childhood, some begin in adolescence, and some can happen at any time. There are also things there that are related to distinct surgical syndromes, so times where there is an abnormality within the brain that has caused the seizure and that may be amenable to some sort of surgical intervention, so that gets its own category. And then epilepsies that have a particular structural or metabolic cause, as we've done a lot more learning about epilepsy and the genetic and other types of underpinnings that relate to this cause. We have been able to put more of them into that category. Unfortunately, probably still about 30% of people with epilepsy do not have a known cause for their seizures, even despite our best testing and efforts. So that brings us to this next slide, and I wanted to just kind of touch upon the fact that epilepsy is very variable. It is kind of a kind of catch-all term that means the brain has seizures, but within and underneath that umbrella, there are lots of different reasons for the brain to be able to generate those seizures. And they kind of fall into these categories that you see there on the left-hand side. So abnormalities in the way that the brain develops, so what are called malformations of cortical development, or there are other terms for them, but basically, the brain is a very complex organ. It has a lot of instructions that need to be followed to generate that, that folded pattern that we are familiar with. And if any of those things goes awry, seizures can often be the kind of final common pathway for that. Epilepsy is often related to brain tumors, not just metastases, which are very common to the brain in adults with a variety of different kinds of tumors. So that's one set of tumors. But also epilepsy can arise from distinct tumors within the brain. Typically, they are now referred to as LEATs, or low-grade epilepsy-associated tumors. And basically, they are tumors that grow very, very slowly, and their main symptom is epilepsy. And they're not malignant. You don't get radiation for them or chemotherapy. The treatment is typically to remove those tumors if they start to generate seizures that are not controlled by medication. So kind of two different classes there. The next would be genetic epilepsy. So we've known for a long, long time that epilepsy has a genetic basis. That was known all the way back to Hippocrates. And only now are we kind of unraveling a bit of those mysteries. So when I started practicing at Children's about 10 years ago, we knew about one gene related to epilepsy that resulted in seizures. And now we have at least 200 that primarily cause epilepsy, and probably another couple thousand that are related to epilepsy in that they cause other neurodevelopmental issues that can travel along with epilepsy. So huge explosion in the understanding of the genetic basis of epilepsy. Head injuries, another big cause, typically not the type of head injury where, you know, the toddler falls off the couch or, you know, the person falls down the stairs. Typically, we're talking about more severe head injuries with loss of consciousness, penetrating head traumas. So things that may have happened to military veterans or people in significant car accidents or other types of accidents. And so those can typically have delayed onset epilepsy. So again, there can be seizures at the time of the head injury, but often the epilepsy starts, you know, a year later or more. And the struggle for researchers is to understand what's happening in the brain during that delay. How can we prevent that person from developing epilepsy? And that's an active area of research. The next would be infections. So things that cause meningitis and encephalitis can cause injury and inflammation within the brain that can not only result in seizures at the time of the infection, but can also result in epilepsy at later points in time as well. There are specific neurologic infections. So herpes viruses have a lot of trophism for the brain. And there are also autoimmune infections. So when the body's immune system goes awry and attacks not just the virus or the bacteria anymore, but attacks its own parts. So there are autoimmune disorders that can be related to epilepsy as well. Again, many times epilepsy is unknown as to what's causing it. And again, that's probably about 30% of people. And then finally, a big category for people, for children is birth injury. So that's probably the largest cause of epilepsy in infancy, is some sort of injury related to either the perinatal period when mom, you know, was getting near term and may have developed high blood pressure, or the baby stopped moving quite as much, or there was a traumatic delivery or something of that sort. Delivery is a very stressful time for both baby and mother. So those are kind of the big categories where we think of epilepsy kind of falling into one of those if we are able to identify a cause. So how does one get to the diagnosis of epilepsy? Obviously, there's a lot of testing that's involved. And I think just to kind of go over some of this. So the biggest thing that needs to happen is to have a careful history being taken by someone who knows what questions to ask. So what happened during the seizure? Did anyone witness it? What did you see? Were you able to film that seizure to show it to someone who may be able to glean some information from it? Often that's difficult because the seizure may have happened, you know, at nighttime in bed, or it may have been witnessed by someone at school, or, you know, something. But if you are the person who is being treated and someone happens to witness this event, you want to be sure to get as much history from them as you possibly can about what actually happened and in what sequence. And then physical examination. So we're going to be looking at brain function. Are there any you know, suggestions that there might be some other part of the brain involved besides the cortex? Are there asymmetries between one side of the body and the other? Are there findings on the skin that may point to a particular cause for seizures? So the brain and the skin come from the same tissue as a fetus is developing. So often those two things are very connected. You know, are there other medical issues that could be resulting in seizures? So all of those things are really important and probably make up the by and large biggest aspect of getting a diagnosis of epilepsy. There is no test, you know, it's not you can't just pee on a stick and somebody says, aha, you have epilepsy. You know, that's not that cut and dry. So it's really a collection of largely historical pieces of information about what happened, plus some of these other things that we'll talk about. And the biggest test that doctors use to help diagnose epilepsy is the EEG. That stands for electroencephalogram, right? And that is basically the recording of the cumulative activity of the brain's neurons from the scalp, or, you know, on the surface of the head. You know, the disruption occurs in many conditions. So if a person has been in the hospital and is very sick, their EEG may be abnormal, but when we are talking about the potential for someone to have seizures, we're looking for specific things, and typically those things are spikes. And spikes represent a group of neurons that are, again, firing all together at the same time repetitively, and that indicates that if they kind of got themselves going, they might be able to generate a seizure. So how often is the EEG going to be abnormal? And the answer is not all the time. So many people with epilepsy will have a normal EEG in between seizures. So when I talk to families, I give them the analogy of, it's like you're going fishing, right? You go to the lake, you drop your line in the lake, and you may or may not catch something. But even if you don't catch something, that doesn't mean that there aren't any fish in the lake, right? It just means that that time you went there, you didn't catch any. And so if the initial EEG is normal, but there's still a suspicion, and it may help you to understand what type of epilepsy the person has, repeating it may be abnormal the next time and may provide that information. In addition, any good EEG should be done with sleep deprivation, and that sleep depriving someone before an EEG increases the chances that that EEG will show abnormalities. And then also it's very important for the EEG to assess sleep. So many people, if their EEG in wakefulness is normal, if they go to sleep, 40% of them will have abnormalities in sleep. So the sleep deprivation in some places acts not only to provoke its own abnormalities, but also to make you really, really tired, so that by the time you get to the EEG lab, you will fall asleep. And that's most of the time what we do it for in children. And typically it occurs in the first few minutes of sleep, so you don't have to have 4 hours of sleep, but if you get a good 15 minutes of it, you should be able to see those things. Sometimes more prolonged EEGs are needed. So if people are having trouble with their medication, it's not working, we don't know if we have the right diagnosis of what kind of seizure the person has, then may bring you in, or your doctor may recommend being brought in for a longer EEG. So, up to a day, up to a week, to kind of capture seizures and understand them a little bit better. That can sometimes involve taking away medications to allow people to have a seizure in the safety of the hospital, so that it can be caught not only on the EEG, but also on video, so that you can understand what the seizure looks like and what the sequence of events is as it starts. So I just put a sample of an EEG up here for you just to kind of see what it looks like. So, so this is what the EEG doc will be looking at when they are looking at those brain waves. And so you can see on the left-hand side here, there are these letters and numbers. So there's different spots in the brain. EEG placement is standardized based on measurements of the head, so that it captures all regions of interest around the brain. And they are arranged in a particular order, and those orders can be changed by the computer. So this is what's arranged in kind of a double banana. So it's 2 strings of electrodes going back around the sides of and top of the brain. So odd numbers will be on the left, even numbers will be on the right. And then these are frontal, polar, frontal, central, parietal, and occipital. So lobes of the brain. T stands for temporal, which is here over the ear. So those letters and numbers kind of signify where in the brain that activity is coming from. And so this EEG is actually showing some abnormalities here in the left temporal region, as well as the left central region. I believe this is the EEG from a person who has Rolandic epilepsy, which is again one of those types of epilepsy syndromes. And then I put the EEG signature of a person during a seizure on this slide. So you can see that this activity is much, much higher amplitude. It's very slow and rhythmic. This is kind of the tail end of a person's seizure as captured on EEG. You can see that there are some spikes in here in this activity. I believe this seizure started on the right side and is reflected onto the left side. So this is kind of it's very dramatically different than that other EEG, which was relatively normal except for those spike areas. This is very, very different and signifies that a seizure is happening in the brain. So next testing to talk about is an MRI. And again, MRI is like an EEG, not all the same. The MRI is usually performed in cases of focal epilepsy. Most people with generalized epilepsy will have a normal MRI. So typically this is designed to assess a particular spot in the brain that may be generating seizures and looking for structural issues within that area. So MRIs are categorized by the strength of the magnet. So, and that's called the Tesla strength of magnet, like the car and the famous scientist. So that's kind of like the pixels in your photograph or the strength of your camera. So 1.5 Tesla is what many facilities and many hospitals will have. To get a good MRI for epilepsy, you want to be sure to at least have a 3 Tesla MRI. They are working on developing 7 Tesla, but that is currently only being used in research settings at the moment. The next thing to know about is something called the protocol. So this is kind of the sequence and type of pictures that the MRI will take of the brain. And there are specific protocols that are designed to look for things that we know are associated with epilepsy. And so those things include how far apart. So basically the MRI is taking little teeny pictures of the brain all the way through the head from top to bottom. And how close they put those pictures together, it kind of makes the resolution of the MRI. So the farther apart you put them, the worry is that you might miss something in the middle of those 2 slices, or you may not be able to kind of understand it fully. So you want thin slices, especially through important regions known to be associated with epilepsy, which include the hippocampus, which is inside of the temporal lobe. I think that it's important that the MRI images be interpreted by a neuroradiologist, not just a regular neurologist, but a neuroradiologist, someone who's trained to look for abnormalities. I cannot tell you the number of times that someone has come to my clinic and said, my MRI is normal. And I get the disc and I look at it and I say, no, it's not. And so I think it's really important to be, especially if epilepsy is not well controlled, to make sure that that MRI is of high quality and that it's read by somebody who's very skilled. The MRI does not typically require contrast. So if there is something abnormal there, contrast may be administered, but not every scan requires that. So it can be safe for people who have kidney problems or other issues. It's a safe procedure. Many people are interested in getting open MRIs because they're claustrophobic, or they don't want to be confined into the tube for that time, and they are not as high quality. So they will not be able to capture what is needed if a good epilepsy MRI is needed. Braces, so many adolescents and children will have those, and they actually provide a fair amount of artifact. So basically, if you look at a picture, an MRI of somebody who had braces, it's like the whole front of their face is just cut off because the braces create so much metal artifact that you can't really see anything there. So if I'm worried about a child who has frontal lobe epilepsy and they are not responding to MRI, I may ask that the family have the braces removed and the scan repeated. So that's like a basic MRI. If surgery or other interventions are being considered, a more advanced MRI may be done. So those can include functional MRIs. They can include special software that analyzes the volumes of different parts of the brain and compares them to each other. Or they do something called diffusion tractography, which kind of traces the fibers that go from area to area within the brain. But those things are really advanced. They have few indications and are not typically used for kind of ordinary epilepsy management. And there I just put up a couple pictures of MRIs that might and point out a few things to you. So this is an MRI. Again, this is a coronal section, so looking at the brain this way, so that the right side is on the left side of the picture and the left side is on the right side of the picture. And you can see that this area right here, I don't know, can anybody see my pointer? Can people see my pointer at all? Yes, pointer?
Yes.
No. Yes, pointer. Okay. So this area here is a little bit different than this side. So this is the hippocampus, which is where a lot of seizures are generated. And this is the ventricle, the fluid-filled system within the brain. And this one is larger than this one. And this hippocampus is smaller and shrunken here compared to this side. So this is something called mesial temporal sclerosis, which is a very common cause for epilepsy, especially in the adult population. This next set of images shows something called a focal cortical dysplasia. Again, one of those times where the instructions for formation of the brain did not go exactly correctly, and there's an area of abnormal tissue highlighted by these nice arrows. The MRIs obviously do not come with those. Someone has to put them on there, but you can see that this part of the folds and wrinkles of the brain looks different than the rest. And these are the different sequences. So each sequence is designed to highlight different parts of the brain, you know, fluid versus the cortex versus the white matter, which is the connections between the cells of the brain. So you can see that abnormality kind of highlighted in those different areas. So again, this is a little bit about treatment. Obviously, as Wendy mentioned, the next Th1nk26 is going to be more about treatment in specific, going into all the different aspects of it, and talking about things that are in development. But just to give a brief overview, typically most people are effectively treated with medications. So 70% of people with epilepsy are treated with their first medicine and have control of seizures. Obviously, that means that 30% do not fall into that category, and that's a more complicated discussion, and those people have a bit of more of a rough ride. Sometimes, you know, the second medication may be helpful, but sometimes there are other things that end up being talked about as types of epilepsy treatment when medications are not working. So epilepsy medications come in a variety of different categories. Some of them act to kind of suppress that gas pedal. Some of them act to enhance the brakes that we were talking about. They work on different types of ions that allow, I tell when I talk to families, I say the brain works in two ways. One way is electrically. So signals get transduced down the neuron by electrical mechanisms, and then between neurons, they communicate chemically. And so electricity is generated by these ions. So sodium, potassium, calcium, chloride, all of those are ions within our body that the nerve cells use to communicate electrically. And so many of these medications act on one of those channels. So you may hear about sodium channel medications or potassium channel medications. Those are all different categories of anti-seizure medications. Obviously, compliance is the key to success with medicine. So if you don't take it, it won't stop seizures. And if you are not taking it and that's because of a side effect, nobody's going to know unless you tell them. So we do know that compliance and adherence improves if medicines are taken once per day. So if you take a medicine once per day, compliance rates are in the 90s. If you start taking it twice per day, it drops to the 80s. If you take it 3 times per day, it drops to the 70s. And almost nobody, you know, half of people can't take a medicine 4 times a day reliably. So, so there are extended release formulations. So if that becomes a problem, to remember to take the medications, there are also apps that can help with that. So to give a daily reminder, have you taken your medication today, and keep track of it that way. And then I think there are various systems, as I mentioned. So those are kind of their first line. So first line is medication. After that is things that are called adjunctive therapies. And so the biggest one being dietary therapies. So the ketogenic diet and then related diets. Those are all designed to increase the body's reliance on fat rather than carbohydrates, which changes the pH balance and the energy use of the brain and acts to prevent seizures. That's the principle of all of those diets. And they go kind of in order from most to least restrictive. So the ketogenic diet, the modified Atkins diet, and then the low glycemic index diet, which is also used to treat diabetes. Those are the dietary therapies. They go from most restrictive to least restrictive, but they also go from most effective to least effective as far as seizure control. The next is surgery, and there are various different types of surgery. So often if people have focal onset seizures, again, seizures that begin in one spot of the brain, additional tests can be done to determine if it's safe to remove that part of the brain and therefore stop the seizures, or is that going to cause too many undesired consequences. And it depends on the type of the lesion. If it's a tumor versus if it's a malformation, those can be, you know, important pieces of information in making that type of decision. Then another type of surgery is called a corpus callosotomy, typically done for generalized epilepsies, often catastrophic epilepsies in childhood, for those drop seizures that we talked about where children suddenly fall to the ground. So this involves severing the main connection between the two hemispheres of the brain, which exists in this area here. So the sides are kind of opened up and then that connection is severed. They usually don't sever the whole thing. They usually sever 2/3, and they have done an well, actually they do usually do the whole thing, and they can do a 2/3, but the success rate is a lot lower. Again, those children or those people usually have generalized seizures, and it's most effective for the drop types of seizures that we talked about. And then the last category is neurostimulation. So the use of electrical devices to modulate the activity of the brain and reduce seizures. And those currently come in 3 categories. So the VNS, the vagus nerve stimulator or vagal nerve stimulator, the RNS, responsive neurostimulation, and then DBS or deep brain stimulation. So DBS is also used for Parkinson's disease. However, this is a different target that's used for epilepsy, a different part of the thalamus, which is a deep structure within the brain. Responsive neurostimulation is often used for people who have a focal epilepsy, but that epilepsy is what we would call an eloquent area of cortex, meaning say the epilepsy begins or the seizure begins with the person not being able to speak. And the area of the seizure onset is right next to the area that generates speech. That's not something that we really want to mess with. And so often an RNS is used in that situation to deliver a stimulus to that part of the brain that hopefully aborts the seizure. It acts to record the abnormal electricity and then delivers a painless pulse of electricity to the brain that can stop the seizure. So I just want to put in a few things about some advanced neuroimaging. Again, typically these are only done as part of a surgical evaluation. So PET, positron emission tomography, and SPECT, single photon emission computerized tomography. So PET, both of these involve a small amount of radioactivity, usually about the same amount of radioactive exposure you would get if you flew from Los Angeles to New York. And it is injected into the body, and the PET uses it to kind of find the area where the seizure is beginning. It's injected radioactive sugar, so the brain uses a lot of sugar. That's its preferred source of energy, and abnormal areas of the brain that generate seizures don't use that sugar and energy as effectively, and so they look different on the PET scan, and we can pick that out and when the MRI is negative. So these would be called functional neuroimages as opposed to a static neuroimage like the MRI, which is just, are all the structures of the brain there, and do they look like they should? This is, how does that structure actually work, and does it work the same as the rest of the brain? The next one is the SPECT, is again a radioactive injection. This time it compares 2 states, one state during the seizure and then another one in between seizures, and it looks at the differences in different regions of the brain. This measures blood flow, so in addition to when the brain has a seizure, it uses a lot of energy, so it uses all that sugar, but it also uses more oxygen and it needs more blood flow. And so this looks at differential blood flow between different areas of the brain and compares them to each other. So next, I just want to touch on some comorbidities. Again, we talked about this new definition of epilepsy, which includes kind of the psychological and neurobiologic consequences of having seizures. And for many patients, this can be more disabling than the seizures themselves. They contribute to the burden of disease that the person feels. They influence outcome, they influence quality of life. They're really important. They can be a significant source of stress for families. They can affect people's relationships. Some studies, and this obviously I'm most familiar with children, show that up to 3/4 of kids have some type of disability going along with their epilepsy that affects their future. And these are usually caused by a lot of different things, right? They can be caused by uncontrolled seizures, by EEG abnormalities in between the seizures, which are considered considered kind of intrinsic factors. So is there also an underlying diagnosis that might affect some of these other things about development and function? Or are they intrinsic factors or extrinsic factors, medications or other treatments that someone is undergoing that may affect how they feel and act? And then this relationship is actually bidirectional. So what we have learned from population studies is that many people with epilepsy will have a preceding history of something like depression or anxiety or some mood disorder that happens even before they have seizures, and that even after seizures are resolved from childhood or from any portion of life, people with that history are at more risk for experiencing some of these comorbidities later in their life, even if the seizures are not active. So I just put some statistics here about some of the areas that these comorbidities affect. So mood, physical function, so motor dysfunction. So many children with epilepsy may also have cerebral palsy, not all, but many. Developmental issues, headaches, sleep problems, behavioral issues, memory problems. And then from statistics that follow patients with epilepsy along, we know that many people are underemployed for their level of education. They have a sense of isolation and feeling like, they can't get in touch with other people, or they don't know anyone else with epilepsy because of stigma and because of people kind of hiding that. Restrictions on driving or on other occupations because of a history of seizures. So that all of that, I think, contributes to what goes along with just, with seizures. It's not just seizures. Epilepsy is more than that. The last thing that I think Sarah and Wendy had asked me to talk about was SUDEP. And this is a scary topic and something that people can sometimes find it difficult to talk about, but it's very important and something that is very real in the epilepsy community. So this stands for sudden, unexplained, or unexpected death in epilepsy. Typically, so it can be witnessed or unwitnessed. Typically, it is non-traumatic. So we do know that people with epilepsy have a higher incidence of accidents and injuries and death related to that. So this is not associated with drowning or some other type of accident, car accident or what have you. But it occurs in someone with a known history of epilepsy. It may occur surrounding a seizure, but there is often not a seizure that anyone sees beforehand. And then if an autopsy is done, it does not identify any other source of death in that person. So the incidence for epilepsy or for SUDEP is that it occurs in 1 in 1,000 adults with epilepsy and 1 in 4,500 children with epilepsy. And that's per year. It is the leading cause of death in people with epilepsy whose seizures are uncontrolled. And it's, as I said, very difficult to talk about, but important for people to know about because it may affect their own choices of how they manage their seizures. It prevents mistrust between the person and the doctor. If they, read about it and the doctor doesn't say anything, then that is not setting up a good relationship. And then it allows the opportunity for questions. Although SUDEP is most common in people with uncontrolled epilepsy, it has been reported in all types of epilepsy, even ones that we kind of used to call benign, or even in people whose seizures are controlled, it can still occur. So I think it's important for every person diagnosed with epilepsy to know about, because although rare, it is a possibility. So I just put here some of the information. We don't know a lot about SUDEP. A lot of people are researching it and trying to figure that out. We think that there may be alterations in cardiac rhythms. Sometimes people have seen a swelling and fluid within the lungs that they attribute to be the cause of death. Some people think that the suppression after the seizure, so if the brain is overactive during the seizure and it slams on the brakes at the end, those brakes are too forceful and the person may not have the drive to breathe, or that may alter other autonomic functions. There are also some studies going on about genetic risk factors. So they are trying to see if there's a link between SUDEP and SIDS, sudden infant death syndrome, and some of the risk factors there may in fact be genetic. As I said, the risk factors are poorly controlled seizures, typically convulsions. So smaller seizures can still result in SUDEP, but the biggest risk factor is convulsions. Young adults are at a higher risk, and that may somewhat be related to their kind of overall general risk-taking behavior, and sometimes they're, wanting to test boundaries and not take medication, but that also may be part of their neurobiology as well. There's a slight predominance in males, also may be related to, risk-taking behavior, but also somewhat potentially biology. There is some thought that sleeping alone increases your risk for SUDEP, and most organizations that are involved in trying to prevent and understand SUDEP are advocating monitoring devices or some other sort of alarm or alert to help people who may be sleeping alone. They have special pillows and a bunch of other things, although none of those things have actually had conclusive data that they prevent SUDEP incidences. I certainly don't think they hurt. So obviously, I think the biggest thing that we talk about is trying to control seizures as best we can. Again, I talked about monitors and devices, and that we need more research so that we can help people about making choices and understand this better, so that we can hopefully someday address it better. So I just wanted to put up a few resources for you. This was a quote that I gave when I gave a talk for camp, and I think it talks about the difficulties of speaking about a SUDEP and what happens when you don't. And then I put some Epilepsy Foundation resources up there, as well as some family organizations. There's a conference each year, Partners Against Mortality in Epilepsy, and then hopefully your physician or others may be able to tell you about research options for tissue donation or for data collection. There's a national registry, a SUDEP registry. So that was my last topic. Sorry to end on a negative note, but I didn't want to take up too much time.